Sorry, there's a bit of technical issues here. So while waiting for Dr. Rafiq and Dr. Iqbal is fixing the problem, this topic is lengthy topic. So I think the slide is about 100 plus. So just bear in mind with you, but most of them are images, X-rays, and I think one video is got of ultrasound again. So just bear in mind with it. Thank you.
So from this, we continue. Okay. Text from this journal, CME management of acute children. The main important is the goal of this department is identify and any life-threatening medical surgical disease condition and relief on the pain management lah. And then in my cases, often the cause is gastritis, gastroenteritis, colic, constipation, pain, and does not require any surgical intervention lah. So primary, the initial step still the ABCs, and then the hydration status, and then the investigation as I mentioned before. This one, okay, this one is a case report, acute abdominal pain and nephrotic syndrome. So abdominal pain, background abdominal pain in nephrotic syndrome is well-known clinical symptom is mainly related to peritonitis. As you know, in nephrotic syndrome, patient will develop hypoalbuminemia. So there will be fluid accumulation in feature space, there will be abdomen. So the presence, although rare, of red umbilicus may guide the diagnosis of suggestive sign of peritonitis. Also in a non-neonatal period, instead of association between TAS and is quite limited. We review all published cases in literature, and to our knowledge, this one is the few pediatric cases of spontaneous resolution of intas in the setting of nephrotic syndrome. Nak cakap agak ya. Okay. So today's CME, this is the outline or highlights of my CME today. Approach to abdominal pain pediatric to recognize common causes of abdominal pain in different age group of pediatric, and clinical presentation, red flag for medical surgical causes, diagnosis, and last but not least, focus in intas and testicular torsion. So what is the dilemma in handling in pediatric case? Common problem with children is a mostly self-limiting condition, however may indicate certain surgical and medical condition. So like macam contoh acute gastroenteritis, it's a self-limited disease sometimes, but sometimes require adhesion, it can be discharged. But some acute abdomen, contoh let's say appendicitis might require surgical intervention. Challenge in the main challenge in pediatric age is the gaining the history from patient and also parents. As a children unable to give exact history, thus unable to localize the symptom. So it's very vague symptom. Patient might come with abdominal pain, sometimes might come with symptom of chest pain. It's actually abdominal pain, epigastric pain. Patient age is the key factor in evaluating the causes of incident and symptom. It's a very greatly or pediatric age spectrum lah. So this is the main challenge to us as a clinician. So it's a brief of pathophysiology of abdominal pain, a recap. There are two types actually, type of abdominal pain. It's a visceral pain and also parietal pain. So visceral pain ni, visceral is a lembut. Visceral is if we make it more easier, is related with the organ inside of our body. Let's say contoh like macam stomach, our colon. Okay. Parietal is the one yang bungkus yang overlying the organ. So parietal peritoneum, that means the cause of pain might be ischemia, it might be inflammation, it might be stretching of the parietal due to all this inflammation of the organ. Pain fibers stimulated and then propagate impulse to the myelinated A delta efferent fiber. Myelinated means if you all can remember, myelinated is a form of nerve that pass through more faster than another type of nerve. So the symptom for parietal pain is more sharp, intense, and localized. Okay. and mostly aggravated by movement, coughing. So parietal sensation are conducted directly into the local spinal nerve from parietal peritoneum, irritated by disease visceral organ. Okay, so the main thing is important is in parietal pain, the symptom is sharp, intense, and localized. For visceral pain, is from viscous organs, stomach, intestine. The same thing happen. Ischemia, tension, stretching. This pain fiber stimulated and then passes propagate through the unmyelinated C fiber within the autonomic nerve bundles. So the symptom is dull, itching, poorly localized. It's more like diffuse, felt in the midline. It's generalized abdominal pain. You cannot localize the pain. Compared to the previous type of parietal, it's more sharp and localized. So let's say, for example, lower esophagus, stomach, esophagus is T6 to T9. Midgut T8 to T12 is a small intestine, cervical pain, and large intestine is like hindgut T10 to L2 lah. So the main thing is the symptom, dull, poorly localized, and fat in the midline. Faham tak? Okay. For example, inflamed appendix. Appendix become inflamed because of ischemia, because of inflammatory process. So the pain impulse pass through for appendix via visceral pain. Visceral pain is the organ inside, located from nerve bundle T10, T11. This pain to refer to an area surrounding umbilicus. So patient will come with pain, dull, macam tak selesa for around the umbilicus, generalized pain, unable to localize. Pain also, pain impulse also generated for irritated peritoneal planum, causing sharp pain in the right lower quadrant. They want more like sharp pain. Okay. Okay, this one is the causes of abdominal pain in children by age. You can see here from neonate, 1 year, 1 month old to 2 years, 2 to 5 years, and more than 5 years. So it's a vast. It's more like macam kalau if I can simplify this, it's more infectious and non-infectious. So easy. If let's say neonate, most common is necrotic enterocolitis, NEC. So might be because of colic, or might be because of the dietary protein allergy. You know, then might be because common is testicular torsion. So 1 month to 2 years, below 2 years, it might be Hirschsprung disease, hernia, intus, common is intus, foreign body injection, toxin, might be tumor, might be UTI. So the more than 2 until 5 years, the common thing is maybe trauma and non-trauma. Trauma might be HUS, hemolytic uremic syndrome, foreign body, appendicitis. Okay. Okay, apart from that, the infectious gastroenteritis might be dengue, okay, pancreatitis, even pneumonia, basal pneumonia. So more than 5 years, the same thing, it might be, apart from that, it's testicular torsion, ruptured ovarian cyst, peritonitis trauma, constipation, AGA, even appendicitis, even DKA. Okay. Approach. How to approach in abdominal pain in pediatrics? First is identify life-threatening condition that require emergency intervention. Contoh ada hydration status, okay, vital sign, tachycardia, hypovolemia, okay, airways. Actually, by through history, you should ask child or the parent any contoh. Let's say you suspected any foreign body injection. Okay, how the child ada makan, ada hilang nak butang ke apa ke. And then through history, you might get it from the waris, the parent itself, or from the caretaker lah. The comprehensive physical examination and test lab and radiographic studies lah. Okay. History is required. Most likely the cause. Kids cannot give history. Dangerous sign given by parent. Contohnya, parent cakap kid was acting normally, tengah taking orally well, suddenly develop choking. SOB ke, become like apnea. Okay, then ask the character of pain, onset. Contoh, child is well, relatively well, playing around here and there, then suddenly develop abdominal pain, 1 or 2 minutes, and then okay, active again. Then develop again pain, crying intermittently, and then associated symptom, actually vomiting ke, anything, cough ke, dyspnea ke. Okay, let's say kalau child become macam irritable, inconsolable crying ke, okay, nampak lethargic or grunting. All this one has you ask truly lah. Because total in school age, localized pain poorly and point at their center of abdomen. Usually sakit dekat mana? Abdomen. Okay. Okay, this one is a character of pain. Appendicitis is, I said before, periumbilical pain, migrating to other right lower quadrant, intense, intermittent and colicky. Pukul 1 sakit, relief, pukul 4 pula sakit, and then pukul 6 pula sakit. Okay, then gastroenteritis is more like diffuse. Okay, of course dia akan datang vomiting and diarrhea, the abdominal pain. Okay, hepatitis, cholestatic, right upper quadrant, gastritis, epigastric, pancreatitis, umbilical and subdefault pain, often radiating to the back. Okay, renal stone, flank pain radiating with mid to lower lateral abdomen. Torsion, very acute, severe, focal, left lumbar, right lumbar. Right flag. This is an associated system with right flag. You should, take more seriously. If let's say there's acute surgical abdomen, pain, if surgical abdomen, contohnya appendicitis, pain generally precedes vomiting. Pain dulu then vomit. Acute medical abdomen, usually vomiting precedes pain. Contoh DKA. Then bilious vomiting means should present bowel obstruction, bilious. Diarrhea suggests gastroenteritis, but bloody diarrhea is suggestive of inflammatory bowel disease or infectious enterocolitis. Classic red color jelly stool impression with intussusception. Okay, then failure to pass flatus or faces suggests of internal obstruction. Frequency dysuria, urgency suggests UTI, cough, chest pain. That one is extra GI cause lah, macam pneumonia, biasa I said before, myocarditis, pericarditis, polyuria, DKA, joint pain, rash, sinus pain purpura or even dengue, vaginal distress, PID, recent trauma atau ada fall 1 hari 2 hari lepas, and then any previous abdominal surgery, pernah buat surgery before, before 1 year old tu pernah buat surgery kat HSB contohnya. So any injection foreign body. So precipitating or relieving factors, macam parietal pain, macam cakap tadi, is aggravated by movement. Relief pain after bowel movement suggest of colonic source including constipation. Lepas dia BO bagi okay. Relief after vomiting suggest of source more proximal bowel, upper lah, or small bowel. Okay, faham tak dekat ni? Gynae pun kena tahu, let's say macam in adolescent period tu, throughout pregnancy, menstrual history, sexual activity, amenorrhea might indicate pregnancy. Sudden onset of mid-cycle pain such as mental smudge pain. Mental smudge pain. Pain in between period tu lah. History taking, good history taking might give clues to what illness the child have. However, through this might be inconclusive still. Okay, stop. Okay, physical examination. Appearance of the child. Okay, appearance, how you see the child. Is it child fussy, irritable, easily trouble, crying? Okay, hydration status, nampak macam mana? Nampak tongue coated ke? Dry, CRT more than 2 seconds ke? Then is it in may hypovolemic lah, contoh lesion trauma, non-trauma, volvular intas. Look, any jaundice tak, suggestive hepatitis, even dengue. High temperature suggested of infection, contoh 39, 38, 40. Abdomen, ini very important lah, abdomen examination, distended ke tak, focal tenderness, shifting dullness. Okay, then for rectal, occult blood, heart stool, scrotal, and then also look for extraabdominal sign, contohnya petechial rash lah. Okay. So abdominal pain usually should be include the genital punya examination. Okay, test, this one should be okay. UPT, urinalysis, full blood count, look for abdominal immunity, Bu's urea crack, CRP. Okay, this one, radiographic studies, you might proceed, you might not proceed or might proceed. Let's say kalau proceed, contohnya plain abdominal X-ray, this one sign of obstruction, air fluid level, distended bowel, perforated, free fluid, free air below diaphragm, and then bedside ultrasound. Okay. This one is the normal X-ray abdomen lah. So, okay. The normal X-ray abdomen should have, this is normal X-ray. So easier if let's say contohnya dalam colon dia ada air lah dalam tu, we can identify easily. Okay, this one is a small contoh X-ray in small bowel obstruction, dilated bowels. How is it dilated bowels? Yang macam yang is a valvular conniventus dalam is actually is a bukan pelita. In our fold, okay, in a mucosal fold of a small intestine, kalau large intestine dia ada hostra. So let's say kalau dilated bowel dia akan jadi macam valvular conniventus ni, ataupun sometimes we refer as pneumatosis intestinalis lah. Okay, this one large bowel obstruction. Contoh basic is dilated transverse colon. Contoh dia ada 3, 6, 9, 12 rules, meaning kalau dilated bowels, usually size dia 3 cm lah. But then if let's say any suggestion of bowel obstruction is more than 6, in a large bowel, usually less than 6 or less than 9. More than 9 is suggested of bowel obstruction. Okay, but for pediatric, there's some literature say you have to compare with the size of the vertebral body. If larger than vertebral body, usually is signs of obstruction, dilated bowels. Ini contoh yang intas, plain film of child with intas shows small intestine obstruction. It is notable of dilated small bowel and the absence of colonic gas. Colon tak ada gas, dia struck at the level of the small intestine. So, yang ni contrast tadi lah. Pas tadi, meaning you pass barrier cannot pass through. So, dia ada level of obstruction there. This one is a ultrasonography of intas. It's a classic donut sign. Okay. Management is airway, ABC, of course, then treat the underlying cause, anesthesia, and then physical evaluation, appropriate imaging. Okay. Indication for surgical consultation in children with abdominal pain. Let's say if after a patient came presented, okay, you assess might be non-specific abdominal pain, you give anesthesia adequately, but then the severe or acute abdominal pain, the progression side obituration, patient more tachypneic or patient more nampak macam toxic looking, and then started to develop vomiting initially or clear fluid, then become bile, stain, okay, then guarding, abdomen, rebound tenderness, okay, sign of acute fluid loss, and then significant abdominal trauma. Okay, contoh dia jatuh 10 feet, 12 feet, okay, then this one need warrant for surgical referral. Oh, yang ni table ni, actually it's a good table but take times to. So, further, you can do abdominal pain, is it, you can go through like macam trauma, non-trauma. Is it trauma? If it's trauma, no. Meaning trauma means, okay, assess the abdomen. Abdomen said what? Previous detention or any history of previous surgery? There's no. Then proceed with periodontal sign. If no, is there any extra-abdominal finding? Contohnya torsion, any hemorrhagic purpura ke macam tu. So, Dr. Anas nak cakap apa ini tadi? This one I don't know how to simplify, but this one need to practice lah yang ni. The most important is you identify whether it's trauma or non-trauma lah.
Yeah, basically that is the approach lah kan. In ED, mainly we deal abdominal pain. Sorry. Okay, because basically in all cases of abdominal pain, chest pain also we are approached and trauma or non-traumatic origins, because that is different. And then furthermore, if non-trauma, is it surgical emergency or medical emergency? So the extra abdominal findings, sometimes most of the sometimes medical causes of abdominal pain can have other extra abdominal finding as well. For example, patient dengue. And do not forget, dengue abdominal pain fever cannot just be acute appendicitis, can also be dengue fever, leptospirosis, even malaria. Okay, like for kids age group, you must think of HSP and H2S. That is also can cause significant abdominal pain in pediatric age group. Basically, this diagram is just organizing your flow of thought. Not to miss. Our aim in ED is basically to detect any life-threatening or limb-threatening condition. So for abdominal pain, of course, there are many life-threatening conditions if we miss. Particularly in pediatric age groups, it's more difficult and more challenging. So that's why all these up to date, they produce all sort of flow chart or diagrams. I think later on the Iqbal can share the slide, then you all can go back and analyze the diagram. Thank you.
This one is a contoh life-threatening abdominal, life-threatening acute abdominal. So, like let's say neonate NEC, volvulus adhesion. 1 month to 2 years old, the most common is intus, HUS, trauma, incarcerated hernia, HPRAM. 2 to 5 years old is appendix, intus, foreign body. More than 5 years, appendicitis, DKA, adhesion, HUS. Okay. Appendicitis is the most common surgical condition, classically presented with the visceral pain. Okay, visceral pain, poorly localized peripheral pain within 6 to 24 hours within the first day to pain become more parietal pain as the overlying peritoneum become inflamed. So because they're inflamed, they're more like sharp pain, well localized and constant in right iliac fossa. So initial the first 24 hours tu might be very vague symptom, periumbilical pain, rasa tak sedap perut, okay, crying, irritable, and then after that baru akan localized pain right iliac fossa lah. Okay, abdominal trauma might be accidental or intentional. Okay, NAI lah, ini very important. Blunt abdominal trauma more often than penetrating injury. This one might cause musculoskeletal injury, bowel perforation, intramural hematoma, laceration or hematoma, liver and spleen, avulsion of intraabdominal organ lah. Yang ni very important, NAI. You should distinguish these kids when presented to ED, the true history, and then also very high suspicious index in non-accidental injury. Intestinal obstruction, characteristic is cramping, colicky, intermittent pain. Causes might be volvulus, okay, intus, incarcerated hernia, or post-operative adhesion. Volvulus is more like macam present within the first month of life due to incomplete rotation of embryonic gut. Symptom is sign of IO lah. I mean bilious vomiting, retention and hematochezia. This is a volvulus, dia macam in a malrotation, dia akan lead to further bowel ischemia pun boleh. This is the history. Intus, proximal bowel telescopic into the distal segment dragging along mesentery. Compression mesenteric vessel lymphatic lead to edema, ischemia, bleeding, perforation and peritonitis. Symptom dia very important, intermittent, severe, crampy pain with associated with vomiting. Appear normal between attack. Child might be active, semua tak ada issue apa. After that develop the same symptom again. And then red color, jadi stool. It's a stool. NEC is one of the most common NEC newborn infant. So characteristic by ischemic necrosis or intestinal mucosa, which is associated with inflammation, enteric gas forming organism and dissecting into the musculary and portal venous system lah. The sign the same, abdominal distension, tenderness, vomiting, diarrhea, and the child itself nampak very septic looking lah. This plain radiograph of enterocolitis. Kalau tengok macam ni, there is a marked abdominal distension due to part of dilated small bowel loop and bubble of gas in bowel wall due to extensive pneumatosis intestinalis. Nampak? Dia macam yang tadi tu, bowel wall, dia akan tickle bowel wall tu. Okay.
Is it arrows?
Yes.
HPRAM ni rare tapi ada juga presentation to ED, congenital megacolon. Suspected HPRAM disease is symptom of obstruction including bilious and then failure to passing stool. Okay. Failure to pass mechanism within 48 hours of birth. Congenital. AGE is more common presentation to ED as well. It might be Macam
Actually masa dalam PowerPoint okey je.
oh, the projector. Banyak sangat halangan ni.
I think maybe next time pakai komputer
Panas sangat.
although it looks
Most of the fans already slow down to
Oh, kan slow down. Brilliant proposal tu. It's a sign.
dari santaran
Dah clear.
yang kena
I can take I can the other way. You have the other.
This one, okay.
okay.
Okay lah, gastroenteritis common. Okay, infectious. Bacteria. Continue dulu. Saya orang tak nampak tapi gastroenteritis tahu kan
Maybe
orang okey.
panas lagi kita.
Marah sangat.
Ini apa tau? Ini baru yang satu lagi tu yang lama. Ini baru. Okay, ya.
Okay, gastroenteritis. Next slide. Okay, oh my god, next slide kan. Common cause but not emergent. Infantile colic. This one, child with heavy colicky pain, then the knee macam letak dia punya lutut tu kat abdomen, perut pegang perut tu. And then associated with severe pain, relief by passive apparatus. It's abdominal colic lah kita kata. Mesenteric lymphadenitis. Okay, might because of abdominal pain juga. Usually this one, dia akan mimic appendicitis, however, pain more diffuse. Constantly diffuse, absent sign of peritonitis, and generalized lymphadenopathy might be present lah. Constipation, okay, usually organic cause, gastroenteritis, and then chronic constipation usually functional cause. Allah.
Oh, okay.
Constipation.
You push to the limit.
Sorry, okay.
Constipation management overview, usually kita ada juga disinfection of the oral or rectal medication if rectal infection is present 2 months. And then dia adalah osmotic lactative, okay, lactulose, magnesium lactative, and then dietary recommendation lah, changing dietary. Maybe some susu tu very high calorie, very high protein, you know, might be advised parents to change to the more light sikit punya susu. Ni contoh abdominal X-ray.
Okay. Before Iqbal proceed with abdominal X-ray, go back. Dr. Ati want to say something?
Typical complaint.
Typical complaint is the same. Usually dia diffuse abdominal pain. Dia ada cuma dia on physical examination tu we akan find lagi banyak campak dan lymphadenopathy, fever, and then vomiting fever lah.
Usually ada TTD instead of URTI.
Ya, URTI.
Dari URTI, but this one bukannya you kena rule out benda lain.
That's good.
Diagnosis, it's not the first diagnosis.
So this one usually dalam ward dia akan proceed ultrasound, then the finding is mesenteritis. That ni macam non-emergency tapi common.
Okay, I just want to add, I think Dr. Ati already mentioned about this. This typically memang ada preceded by infection. Okay, tapi like Dr. Ati said, mind us that it's diagnosis of exclusion. It can produce a tenderness all over. It can produce a tenderness over the right iliac fossa. Why? Because sometimes the inguinal lymph nodes is inflamed. So the inguinal lymph node become lymphadenitis. When you press that, it's tender. Okay, that is why additional point is important to examine, to expose a little bit lower or even palpate a little bit lower to see the inguinal lymph nodes, and also sometimes extend further down to your testis if there is a boy. Okay, like I think Iqbal mentioned a few times previous slide. Okay, testis, always remember they can present with mimicking acute appendicitis. Okay, very pain, very tender, come early in the morning. So do look further down lah, rather than just in the 9 quadrants of your abdomen. And the next topic is constipation is also a very, very challenging diagnosis. I think even for specialists to level a kids with constipation also sometimes we need to crack our head. Okay, so do exclude other things and we need more history is constipation. Don't just because I always see we tend to make diagnosis just based on the picture loaded on abdominal X-ray. Okay, it's actually more than that. More of the history. They can tell you how is the bowel habit of the children, how is the stool consistency. Okay, so do not just commit just solely based on the so-called picture load. Okay, always rule out other more surgical emergencies before committing to your constipation. And be careful of the habit of giving rabbit enema for all children. Okay, so sometimes it can get worse. So I mean, unless you can tell the mom say the memang passing need to strain sampai menangis kan. Sampai menangis, tahi memang keras, then maybe you can stick your see whether there is any hard tool down there, okay, before committing to give your rabbit enema. Okay, can continue, bang.
Belum. So far ada soalan tak ada? Ya,
Okay, role of leg pullers. At what age group do we give leg pullers? Student ada? One year. Okay. Be careful with infants. Infants usually we try to avoid. And how about the dose? How about the dose?
Isi hidup.
Okay.
Boleh Faiz. Faiz datang.
Yeah, the dose actually kita pun tak ingat dia punya dose dia ada per meal gram per dose per day lah, dia ada dose per day. Tapi usually less than 1 month old we can pull out to routinely bagi tidak terus lah. They can cause excessive diarrhea lah. Excessive diarrhea ni datang balik diarrhea pula nanti. Okay. Boleh continue.
Boleh.
You guys can share the screen.
Pedih kan?
Okay, next topic is the
Lowest is 2.5 mil. Dose yang untuk small baby 2.5 mil kan? ETS video ETS.
so abdominal X-ray lah. Okay, abdominal X-ray, there's two views that commonly requested in emergency department. First the anti supine or PA erect lah. Another view we should include is lateral decubitus horizontal beam view with the patient roll onto one side. It's a useful alternative to erect AP view since patient is unable to sit or stand lah. Dia satu dua tepi lateral decubitus. Okay, and then KUB X-ray. Okay.
KUB not routine audit lah, sebab kalau KUB by right radio need to patient. So basically takkan nampak kalau kita CT audit kalau tak ada proper correct. Thank you.
So this one is a plain abdominal X-ray. So kalau this one you have to go through training, tengok banyak kali then can hafal. So the one yang macam shadow bawah tu is a liver. Okay, right kidney dia dekat dalam 11-12 ribs. This one 12 rib, left kidney, spleen fracture spleen. So this is a sacrum. Tahu dah ni. This is a lateral decubitus lah. Okay. Indication. Okay, what's the indication for abdominal X-ray? Useful certain defined pathology such as abdominal gases, mass, bone, stone, nak tengok. Might be useful in undifferentiated abdominal pain with provisional diagnosis of say toxic dengan colon, bowel obstruction, bowel ischemia, perforated viscous with abdominal free air. Ask for direct chest X-ray. Ultrasound is better, higher sensitivity and specific for perforation. So KUB X-ray, nak tengok let's say kalau ada stone ke, then foreign body. Foreign injection. Okay, there's actually dia cakap ni there's no evidence correlating abdominal X-ray with constipation. Okay. Approach, first of all, nak tengok X-ray, of course check patient demographic name, nama, and then review the bowel gas pattern. Is checking any intra-abdominal organ looking for enlargement, macam liver tadi mungkin besar ke, shadow ovation sampai more than 12 ribs. So and then scrutinize film abdominal calcification to let's say kalau contoh let's say memang ada some calcified ke foreign body ke, they analyze the visual skeleton and check visual lung bases and document your finding medical notes lah. Bowel gas pattern, bowel can only be seen if contain air or gas. If it is completely fluid filled, bowel will be indistinguishable from its surrounding, such as stomach, small bowel, large bowel. Kalau dia ada contain gas or air, baru boleh visualize. Okay, stomach dekat mana? It's the left stomach lah yang tu, bulat besar tu. Okay, left midline beneath hemidiaphragm. Sometimes just a small volume of gas in the fundus. Do not mistake a rim of gas for pneumoperitoneum. Okay, mana air below diaphragm, tapi on the left of midline beneath hemidiaphragm. Kalau right side is below diaphragm lah. Okay. Small bowel. Okay, metadata 3, 6, 9, 12 rules. Less than 3 cm wide, tend to be central. Only seen if contain gas. Okay, mucosa full. Metadata valvular condimentous to traverse the bowel lumen and are closely spaced. Okay. Large bowel. Large bowel less than 6 cm wide. Okay, ascending colon up to 9 cm peripheral, ascending and descending colon in fixed position laterally. Haustra fold do not go all the way across the lumen and widely spaced. So bezel tadi tu dia ada haustra lah. So 369 rule. In general terms, small bowel should measure less than 3 cm. Large bowel less than 6 cm. Circumscrimal colon should measure less than 9 cm. If bowel measure greater than it, suggested of dilated bowel lah. Mass. Contohnya mass ni look the size of position of the solid organ shadow of the liver, spleen, kidney and bladder. Okay. Look for dilated calcified site or ruptured aortic aneurysm or adjacent bony trauma. Yang ni kalau contoh X-ray dia nampak macam hyperdense, calcified. It might be calcified aorta, might be calcified ruptured aortic aneurysm ke. Okay. Cuma yang source sign ni saya Dr. Rafiq ke Dr. Source sign. Actually dia saya baca pun tak faham lah. Dia from plain X-ray tu dia cakap source sign, saya baca pun saya tak faham. Dr. Source sign. Tak apalah, nanti kita
we can go through that later.
Later, okay lah. Bone, nak tengok bone in abdominal X-ray, you might incidental finding, tengok macam ada mass or ada sclerotic changes. Okay. This one is a referred pain lah, might be degenerative spine disease can present with abdominal pain juga. Stone, look for renal, urinary or bladder stone calcification. This one through X-ray KUB lah, you can see classification of the stone tu sendiri. But okay, 80% or 90% of renal stone are radiopaque. So another 10% tu tak radiopaque. Meaning kalau let's say you tengok X-ray, you memang very sensitive, macam contoh macam it's a stone, tapi you cannot find any radiopaque, you still cannot rule out renal stone. Ini contoh classification. Ya, macam tuan cakap step 1. Apologies. Small bowel dilatation more than 3 cm. Okay, usually kalau small bowel normally less than 3 cm. If more than 3 cm, we suggest a small bowel dilatation. So the valvular preventers are much more visible, quite spring appearance. Spring dok main macam tu quite spring appearance. Common cause might be addition to previous abdominal surgery, hernia, or maybe some neoplasm lah, CA. Large bowel, common cause, colorectal carcinoma, diverticular hernias, or volvulus. Okay. Volvulus are twisting, macam twisting of the colon tu, and most commonly occur kat sigmoid colon or cecum. Patient of volvulus are high risk of bowel ischemia because decreased blood flow because of the twisted tu. Sigmoid volvulus are characteristic of coffee beans appearance. Cecal volvulus often described as having fetal appearance. This one, very important sign, pneumoperitoneum, erect chest X-ray or left lateral abdominal X-ray, can see air below diaphragm above the liver. Ni, belah kanan. Gas on X-ray may persist for 1 week post laparotomy. Ini very important. Yang ni regular sign tu, both inner and outer border of bowel well defined. Inner dengan outer well defined. This one, the pneumoperitoneum supine X-ray is macam football sign. Air outline the entire cavity within a football shape. With a football shape. Nampak? Ni pneumoperitoneum. Pediatric. Ya, American football. Tu bujur tu. Yang ni supine abdominal X-ray, interloop triangular lucency. Tu nampak macam segitiga sikit tu. Triangle of gap between two loops of bowel and abdominal wall. Continuous diaphragm sign. There's a sufficient air beneath the diaphragm. Usually diaphragm kan right and left, dia tengah-tengah dia, the spine tu, dia tak continue. So kalau dalam pneumoperitoneum dia akan continuous between the air tu. The line. Dia cantum duduk right and left. Okay, ini same juga. Pneumoperitoneum juga yang tu. Subhepatic air, same. Cupola sign. Cupola sign is air accumulation beneath the central tendon of diaphragm. Ini. Okay. Cmemo. Apa lagi ni? Same ni. Banyak sangat. Now this one double bubble sign. Appearance of subdiaphragmatic gas under the left hemidiaphragm. Ini. Dia macam ada double bubble sign macam balon, dalam balon tube, dalam balon ada lagi. Kalau ni nampak ni sini is a sign of pneumoperitoneum. Kan tadi usually kat sebelah right side kan, this one left side kita akan ni macam stomach punya gas ke apa. No, this one double bubble sign. Sign of pneumoperitoneum. So in this case usually kita akan limit, usually kita pneumoperitoneum or bear in mind right side saja, no, can present to the left side juga. Okay, colitis, thumbprint. Mucosal thickening of the rostra due to inflammation and edema appear like thumbprint projecting into the lumen. Di lumen, so macam ada kita pegang lumen, pegang the colon tu, macam ada thumbprint kesan. Banyak. Focus for intas. So focus is ultrasound in emergency department ni, comparative relation of plain film ultrasound CT diagnosis of IO contohnya. So result is the CT sensitivity is 93%, specific 100% for diagnosis of IO. Ultrasound sensitive 83% and specific also 100%. So in this case, contoh dekat ED, usually kita ada ultrasound, mana semua buat CT kan. So ultrasound is a choice of diagnostic. Okay. Teknik. Okay, yang ni just basic physics of the ultrasound. Ultrasound is a sound, ultrasound. It's a sound propagation through different medium. Contoh, let's say kalau air, you see all the molecules kan duduk jauh-jauh. Yang fluid tu more rapat. The soft tissue more rapat, the stone all more rapat lagi. So yang what I understand is that sound, they hit and then come back, hit, come back, hit, come back tu dia more dia akan define contoh dia more hyper-echoic. So unechoic, less echoic. So hyper-echoic itu macam contoh yang perpejalah stone, bone, fibrous tissue compared to the fluid tu macam sometimes unechoic, hypoechoic. So which probe kita nak guna? So ada two probes. Satu is the very high frequency and satu lagi low frequency. So the high frequency, kalau ikut from physics last time, frequency equals to 1 per amplitude. Meaning frequency, higher frequency, low amplitude. Okay. So frequency, the higher frequency is the one yang abdominal probe yang curvilinear tu. So yang linear probe tu less frequency. So higher frequency, high frequency is the abdominal punya curve. Balik
No, what you wrote here is correct.
Yeah, betul. High frequency is a straight probe. That one used for examine the local, the superficial structure. Contohnya nak scan, nak cari vein, nak cari IJC ke macam tu. So the low frequency probe ni untuk yang deeper. Contoh yang tengok intra-abdominal punya structure. Patient yang obese kita boleh pakai yang tu, dia more deeper.
Dia low frequency.
More frequency.
Dia low frequency, dia punya amplitude yang amplitude tu very panjang. So dia boleh jalan
jauh.
Dalam.
Lebih dalam. So that's why you can see visible clearly the abdomen, dalam liver, contohnya. Inilah. This one is low frequency, this one is high frequency probe. Okay. Okay, dia examination technique of JNE dia ada satu. Okay, this if you see this one is a move, we call it lawn mover move lah. Tak tunjukkan ni. This one. So it's like macam you slide, like macam you potong rumput. You ada satu you punya rumah rumput tu, you pergi depan, then turn right, patah balik, turn right, patah balik, turn right. This is the suggested punya really the absence of the colour tu sajalah. So meaning dia ischemic, dia tak ada flow of blood kat situ. So aduh, punya soalan tadi.
Yeah, usually we compare left and right.
Left and right.
Then you compare usually the one yang ischemia, there's the lack of blood. So memang significantly memang tak ada compared to the other side.
Cara nak scan dia, support the test total tu dengan vein capture to elevatekan dia punya scrotum. Dan linear probe. Jangan lupa cover ya.
Cover. Oh, cover pro. Okay.
Need to be covered.
Oh, ni tak cover. Patutlah dia tahu.
Well, ini right? Cuma bakteria apa?
One question as well. People say you got extreme suspicious of torsion and a 7-year-old boy. So then because surgical asks for formal ultrasound. Is it the proper way, or you want to request formal ultrasound first ke, ataupun you want them to review first?
Kalau saya request ultrasound.
Or maybe you request ultrasound first or before referral.
Terus kalau dah datang ke diagnosis, saya lah. Kalau diagnosis tu, for me, come up with diagnosis of torsion tu, usually I'm particular lah, itu memang torsion.
Okay, mind you, it's actually ultrasound is not a must in testicular torsion. It's actually a clinical diagnosis. Okay, why you do ultrasound is sometimes if you are not sure, I mean, you want to exclude other things, for example, abscess, orchitis, other things. But yes, now we have modality in emergency department, and then consultant we have ultrasound punya sifu kayak ini pun ramai. So you can do a focus bedside kan, tapi formal do not necessarily must wait. Nanti regular pagi, okay, buat kami morning lah, patient datang pukul 2 pagi, buat kami morning ultrasound. There is definitely a no, big no for that testis, that why we lose the testis. But you can get classically diagnosis classical, then go straight to OT. Not what formal ultrasound. Itu wrong mindset lah, sudah ultrasound formal. Surgical and both, semua nak minta kan, masih lagi go for ultrasound kan. Okay. Unless they can come very fast, no need to wait for full FBC, use semua tak ada. Okay, once you diagnose, refer straight. The time is tested kan.
Time is testicle.
Okay, thank you. It was very lengthy presentation. Just like maybe comments.
Ada nak tengok video.
Mana video?
Traffic buka video. Time is testicle.
Oh, by the way, just a quick addition on the asking about okay. Okay, do remember that our leg tulus ni ada banyak concentration, banyak strength, and ada 10 gram, 20 gram, 50 gram. I think us is 50 mil per 10 gram kot. Kalau nak misalnya command ATM ni kan. Bila 5 for adult is up to until 40 to 60 gram per day. Okay, so adult usually kita bagi 50 mil BD or TDS kan, atau 50 mil ON. For pediatrics, okay, just to correct a bit, tadi not 1 year, 1 month. Yang confirm boleh bagi prescribe is 1 month and above. 1 month and above. Kita tukar dengan Revin tadi. Revin lagi lower sikit lah. Untuk tulus 1 month and above. Less than 1 month not recommended.
Okay, you take a play, you explain.
Yes, however, in most of the recommendation under 1 year old for leg tulus must have doctor's manual, meaning that you cannot just bagi tahu parent bila constipate we beli leg tulus. Let's know. Because most of the time under 1 year old is macam related to the milk, ataupun dia punya bowel habit is like that. And some baby ada maybe twice a week, some maybe twice a week, and some every day, some twice a day. So you have to explore more regarding the susu, the dietary, and after the weaning dia makan apa semua tu, the hydration status, etc. Okay, but it's safe after 1 month lah, once a month, yeah. And the dose for 1 month to 1 year maybe 2.5 mil OD or BD, 2.5 mil. And then as you go older, the dose increases up to about 15 mil BD or ABS lah. Okay. For Revin, definitely small lady, you have to be careful because sometimes when you give too many repeated Revin, it can cause what we call something at our anus can anus irritation. So nanti the child akan develop secondary constipation because of the pain. Dia tak nak they can cause anus fissure, traumatized, and also mucosal irritation.
Dia tak
So
keluar.
bila cause mucosal irritation nanti baby dah tak nak berak, so lagi balik. So doesn't trigger the cause. That's why rabies is not really recommended unless memang tu indicated lah.
No, kita tak share yang ada QR code lagi.
Boleh cuba non-pharmaco punya dia lah. Or even the dietary punya. Right, any question or other EPs or anybody want to share or add anything regarding our topic?
Dekat rumah selalu kena.
Those at home, any question can turn on your mic.
Open.
Oh, now they're dietary. Ada soalan?
Perintahkan.
Berarti okay, berarti. Maybe you all can start turning on your camera.
Okay, doktor.
Ni, weh, cakap. Ayo.
Tengok gambar dulu ke? Hai, dah gambar.
Scan.
Oh, okay.
Okay, everyone, you can scan your QR code. Open your app and scan the code. Please to get your CPD points. I will give some time. Okay. So after this, we will open the floor for questions, and then Dr. Bey will handle the Kahoot session. You please scan kat sini.
Ada orang MMA punya member ke ya?
Tak.
Siapa yang tak?
Dia tak payah apa.
You kena buka MMA app. I think ni hanya untuk doctors lah. Kalau MA, PPP semua dia tak. Boleh lah, Yusri. Kan?
Macam slide tu yang tu yang dia kan. Dah bisa.
Come on, let me share.
Ada soalan? Azam?
Satu lagi bentuk betul
Kepada budak.
Saya pun biasa ni. Sebab kalau saya tak kampung pun tahu dia. Sebab dia tu hanya minum susu badan dengan susu saja. Kalau kita pun tu memang agak positif lah kata kaum kecuali baby tu macam kalau sebarang pun sometimes it happen tapi PU ni okey cuma kalau kami practice tu katakan 3 hari tu selalu ada patient untuk buat anal stimulation for first 3 days lah. After that dia dah 3, 4, 5 hari tu tak ni dia kembali lagi waktu tu macam kadang-kadang call SMS ataupun sometimes kami consult fix lah. So dia perlu bagi glycerin dalam 1cc macam glycerin. Glycerin tu lebih kurang macam bukan tak? Kita masuk buku macam apa tapi dah habis. So ikut generation 1cc lah. So kita observe dia tengok sometimes kita observe lah. After anal stimulation, kita macam suruh dia macam jari ibu, dia bukan dia boleh jari ibu, so massage dekat dia untuk dia dengan dia lah. Kita bagi tempoh 3 hari juga, saat kita 5 days bagi macam
Ni you want to explain your video lah. I thought you nak tengok video. Tak ada, tak ada. Nah, man. Tingkap.
Tu hati bagi video tu. Video. Video. Oh ni ha.
Yeah, okay. Tengah, yes.
So this a video of intas ultrasound dan si tengok tu bukan target sign, you can see bowel peristaltic movement lah. Yang tu lah saya nak explain.
Video of interception lah. This.
Ya.
Lagi.
Belum ni bowel. Bukan.
Saya yang tadi.
Yang tu.
Which one lah? Is that normal?
But there's no signs of ultrasound pending. Number IO. IO. Apa signs ultrasound? Ultrasound belum pergi kan IO kan?
Oh, ni untuk ultrasound.
Ini ultrasound untuk intas ataupun kita aja IO ke kan? Bidirectional kan, peristaltic kan. IO usually kalau normal balik directional, so you see bidirectional peristaltic. The bowel content, one thing. And then you see bowel wall thicker, so this sign of IO again.
Pusing-pusing satu.
Yeah.
To and fro.
To and fro bidirectional movement of bowel content. Then of course the size of the bowel is related. But when you scan a normal patient, normal bowel movement is unidirectional kan, dia tak gerak kiri kanan macam tu. To and fro tu kan.
Dan kita tak apa untuk tengok bidirection. Spesifiknya kita tak ada kanan.
I think we can proceed with the Kahoot session. Okay, everyone get ready for Kahoot lah.
Dari tambah tu. Habis saya tengok lah.
Apa itu maksudnya?
Oh, it's in the course. Yeah, sorry. Yeah, what the?
Oh, so kau nak pergi losi aja. Dah berdarah di dalam. Memang losi pada air.
Tak boleh nama kita defer tu. Kenapa kita defer?
So,
Waktu kali Komandan lagi defer. Tak ada kata yang sendiri.
oh, si jadi tu.
Jadi
Tak ada, saya fikir itu.
kan? Sekarang boleh lah. Yang bodoh dia buat ingin. Tak
Tak fikir.
Lepas tu nak sebagai komandan. Tak dehul.
Oh, ya. Oh, masuklah sistem.
Masuk sistem. ICC memang ada betul. Kalau nak cancel, banyak lepas tu ada kena.
Boleh tak?
Kadang-kadang pergi overseas je. Kedua?
Selesai dah. Dia biarkan. Ini apa? Nama apa?
Tapi kat
Saya kasi nak keluar.
Oh, kat skrin tak keluar?
Mana ada tanya.
Boleh.
Apa?
Boleh ada bagi saya.
No, dia tak keluar.
Oh, audience tak keluar. Sekejap.
Oh, dia tak keluar.
Dia keluar tapi dia
Tak bergerak.
Saya akan main game. Remote. Ada brightness. Indah.
Siapa yang present? B yang present lah. Oh. B yang buka kan?
Ya.
So B boleh present window katanya. Seems to work. Okay. Dia nak ajak I datang saja. Saya dapat. Tak apa. Kalau dapat high score memang saya lah tu. Kalau dapat skor rendah, ada orang fitnah.
Ada mic pun. Benar. Okay. Restart.
Yeah, they don't know how to describe the pain there, so they always say. Oh. Oh. I don't have the pencil. Just something, but dia tak ada diarrhea. Dia increase appetite, but loss of weight. Because once they eat, they will vomit. So they keep on wanting to eat because they're very hungry. But after they eat, they will. Then it calls hypokalemia, not hyper. Then epidemiologically, memang higher the first born child, especially if it's a first born boy. So the winners of this week's and last week's Kahoot, please text me. Please send me a PM. Thank you. Thank you, everyone. Bye.
Okay, thank you everyone. Thank you to all who joined and who prepared for the CME. Thank you very much. See you. Happy berpuasa next week. Bye.